Today, I'm going to share with you some ideas from a clinical perspective about what I expect or what I'm looking for with regards to the COVID storm. When I talk about the COVID storm, in case you've not seen me before, I'm Dr. Philip McMillan. I've been focused on autoimmunity around COVID-19 since 2020. I've been following the clinical presentations, looking at the research, and I think that I'm now able to integrate almost every aspect of disease presentation. And so, what I'm going to be doing here with you is giving you an idea as to what I'm thinking about and what I'm looking for when I speak of a COVID storm. And this is what I mean when I say a COVID storm: spike triggered autoimmune response mechanism. And in effect, this is primarily what I expect can happen after someone has been immune primed and then has further systemic exposure to the spike protein, usually from an infection. And this is essentially what I think the storm looks like. When you have on the left recurring COVID infection, on the right, COVID vaccination with immune priming, the two together produce what I think is a COVID storm, an immune response that is way beyond what we would expect from just an infection. That's a hypothesis. And so, therefore, I'm always looking for evidence to prove if this idea is correct. So let's going to take this apart. And what I'm going to be showing you here is a very important paper that was shared with me from someone in Japan. Thank you, Ivo, for severe refractory diarrhea associated with COVID-19, a case report. It was published in 2024. And there are some extrapolations we're going to have to do because there's a bit of detail that is missing in order for us to do this completely. Before I start, as I said before, because I'm looking at COVID storm, I'm looking at the way that it can present in multiple parts of the world based just on the observation of the science. If you haven't seen this yet, actually, this is so important. It is looking at what happened for what I call the neurological storm, India's most dangerous disease X outbreak. And this is talking about Guillain-Barré in a specific part of India. And I've been watching this now for a little bit over a month, and I'm realizing that this is not normal. And so, therefore, I'm going to be taking the science around that apart and demonstrating, hopefully by the end of that presentation, how to look for COVID storm in different parts of the world. I'll be showing what happened there in India is quite unique. And then you will see how it dovetails into, say, what happened in the Congo with malaria. And you then, once you understand how it works, you can then make sense of what is happening in different parts of the world. Additionally, I'd like to encourage you, because I'm focused on spike and spike related systems, if you're interested in my ideas on the root spike detox protocol, if you haven't heard the most recent breakthrough research showing that almost 30% of certainly people who have long COVID type symptoms have circulating spike for up to 700 days. And these are the questionnaires that you can fill in, and it will help me to understand a little bit more about you. Absolutely free, and critically, you can join in with me on a check-in. So let's get back to the science here with regards to this concept of a COVID gut inflammatory storm. So let's just summarize the principle. What I'm predicting is that where you have immune priming, which is primarily going to be in a vaccinated cohort, it's not that it cannot happen in the unvaxxed. If they have recurring infection, it can, but that's a much smaller percentage. So the question is, what happens to people who are having recurring infection? What are the extremes? And what is likely to lie in between? This is another important point. Once you see a case report like what we're talking about here, this is an extreme case. This is why it got into a published case report. But it doesn't mean that the science that they are observing is not relevant in different degrees for different kinds of presentations. So let's work through this paper here in a few little bits of detail. This is the paper. The first thing that you'll notice is that the information on the paper was submitted or received on January 17th, 2024. It was accepted on the 13th of May, 2024, and then published June 14th, 2024. There's a reason why I'm highlighting this date, January 17th, 2024. It is also from Japan. I'm so impressed with the Japanese because they have been so to the point. They look at everything, they study everything. I wish that was a pattern that we were seeing in other parts of the world. However, the important point about the start date is that I have to presume that this case occurred sometime in 2023. And the reason that I have to presume that is that they gave general information, but they weren't quite specific. Because my first question, as I looked at the case report, was this patient vaccinated? He was 50 years old. And I can't find any details in the paper that specifies that. And so therefore, if it isn't before 2021, there's a pretty good chance that this person was vaccinated. And one of the critical things we need researchers to do is please just tell us their vaccination status. Don't presume that it is irrelevant. In order to understand what's going on, we absolutely need to know that piece of information. So let's break down this case and tell you exactly what happened with this case, and then we'll look at what I think was going on. So the first thing is that he's 50 years old. He has no medical conditions, and he was admitted to hospital with a pneumonia caused by COVID. Now, just because someone is vaccinated doesn't mean they can't have a COVID pneumonia. So it's important to note that it doesn't mean that just because he had COVID pneumonia, he was unvaccinated. But he had a relatively severe episode in that he needed some steroids, his respiratory status deteriorated, and he needed to be put on mechanical ventilation on about day 7 after the onset of his COVID symptoms. Fits perfectly with what Dr. Shankar Shetty was noticing. Day 8 almost, you'll probably find that their day 1 may have been a little bit earlier than what they had thought. And he also needed extra oxygen support. He managed to improve. He had a tracheostomy performed. That's where they put a tube into almost the throat region. And that was day 20 after the onset. And then he was sent to rehabilitation. That's the baseline situation that happened. So important to understand. He had COVID. He had a case of severe COVID. And so that could push the question towards whether or not he was unvaccinated, because you tended to have severe COVID responses in people who were unvaccinated, tended to be more frequent after vaccination was rolled out and a lot of people had natural immunity. We don't really see it as much. However, there is a cohort of people who still get severe COVID-19, whether or not they were vaccinated. Important to note that in terms of natural immunity, you rarely see severe COVID-19 because of how it occurs. You can't have delayed interferon if you have good natural immunity, and so therefore you're unlikely to see severe disease. So that's a question mark that we don't know, and I wish they had put it in. However, it's still important to understand the principles of the COVID storm. So just remember, he has been admitted to hospital. Day 20, he was then transferred for rehabilitation. And now we're coming to the second phase of his presentation. This is now where it gets very important to notice. So when you look back at the case report here, he was then, he experienced diarrhea before the transfer on day 43 after the onset of COVID, which then gradually worsened. So he was passing 6 to 7 liters of stool a day after the transfer. And so therefore he was brought back into hospital. He was too unwell to be out of hospital. And so they had to bring him back on day 62. So again, let's take the sequence. He had COVID. He was on intensive care or respiratory support. He had steroids at the start. He gradually improved. And on day 43, he starts to have diarrhea. So day 43 is like 6 weeks down the line. Goodness, now isn't that unusual? So then we're talking 6 to 7 liters of stool. So you'd have had to have a lot of fluids. And so then he was transferred back on day 62 after the onset of COVID-19 symptoms. And when admitted to the hospital, he had watery diarrhea, but no bloody stools. We look for blood in the stool in terms of inflammatory bowel disease. And so that was an important clinical observation. He had a fast heart rate. His blood pressure was okay, 120/83. His weight before COVID was 114.5 kilograms. So this is an important point in terms of his weight was a risk factor for severe COVID-19 in the first place. But he went down to 94.6 kilograms at the time of readmission. So he has lost a lot of weight. He's passing a lot of stool. 6 to 7 liters of watery diarrhea is an incredibly high amount of stool. And he would certainly have had to have a lot of fluids to support him through that period of time. So now they're trying to figure out what is going on. And so then they start doing the investigations. They do a contrast enhance, a CT, computed tomography, which reveals severe edema of the colon and intestinal fluid accumulation of the entire small bowel. We'll show a picture of that in a little bit. His blood test showed his blood count was low. So hemoglobin was 6.3, which was quite significantly low. His albumin had dropped off significantly. He had marked inflammatory markers, and he was negative for the usual C. diff toxins, because that's what they were thinking about. And he was negative for the other E. coli toxins as well. So at this point, they still don't know what they're looking for. They find that the whole of his gut is inflamed, and this is what it would look like. So this is the CT here that shows that this region here is quite inflamed here, and this is likely to be some small bowel. It could actually be large bowel in terms of the descending colon. And over here is the liver. And over here, yes, there is some more inflammation here. So this may be small bowel, large bowel here. And when they did the scope, you can see how inflamed this area of the colon is, suggesting that this is duodenum as well. So they looked from both ends, and it's quite severe inflammation here that was going on. And so you have to look at the timelines. This is day 62 and beyond. So, this is 2 months down the line. And they then take samples, and critically, they then start to look for other abnormal patterns, because they found, this is where it's important, then they found that he was positive for cytomegalovirus, CMV antigen. CMV is one of those really it's a really problem virus. If you have a viremia, that means the virus is spreading through the bloodstream, and it can cause really severe disease. So the first important connection you have to see is that, one, he had severe COVID-19. And remember, as I have been explaining before, COVID is associated with immune suppression by specifically targeting certain immune cells. So it's not surprising that he then ends up with severe or cytomegalovirus. So another virus, another almost not quite a co-infection, but another virus coming right behind it. And this is what I'm explaining to people in terms of this viral invasion. You will see COVID first, and sometimes some people don't even see COVID. They don't even know they had COVID. And then they have, say, the influenza, or they have the RSV, or if they have the strep throat beyond it, because it has damaged that immune system. So Essentially, now, when they have found the CMV and they did the biopsy and everything, that's when they suspected enterocolitis, that's inflammation of the large bowel. They think it's more associated with COVID 19. And then, therefore, they gave him methylprednisolone pulse, intravenous injections, 1,000 milligrams per day for 3 days. Now, I think this is something that is really, really important. If anybody clinical is looking at this, just reflect on something. When you have these sick patients and you suspect it could be COVID related, if you're going to get them better, you probably need to be using serious doses of steroids. And when you compare what they did here in Japan with the steroids that they used, is that they gave him 1,000 milligrams of methylprednisolone. This is when we think about what people are giving in terms of dexamethasone for severe COVID, they're giving like 40 milligrams of prednisolone, equivalent dosage, nowhere near that kind of treatment. And this is now where I think this is why I keep on talking about this COVID storm, because if from a clinical point of view, we don't suspect it, we can't intervene to get the patient better, because if you don't think about it, you will never think of giving somebody steroids when they have CMV and COVID. So you have to be looking for the COVID storm in order for it to make sense. Here is what happened when they did the pulse methylprednisolone. So this is where they gave 3 doses of 1,000 milligrams. And this yellow bar represents here the amount of stool. So he was between 6 and 7, almost 8 liters of stool. They then give the methylprednisolone here when he's at about 5, between 5 and 6 liters. And immediately, within a day or two, his stool drops right down to a baseline. And it stays there along with further immunosuppression. And it shows you just how critical the methylprednisolone, the immune suppression was in terms of settling this down. And we can see in black, his CRP here was not that high, but it came right down straight afterwards. His albumin gradually increased, his blood count gradually increased, everything changed with the immune suppression. And that's the principle that I'm explaining to people, is that that COVID storm that we're talking about is essentially the immune system going into overdrive. And that's where the presentation, the clinical presentation, can sometimes be very, very unusual. And without the use of steroids or immune suppression, these patients can die because they just won't get better. This is the reason why I'm so focused on the COVID storm, because it has direct clinical and management implications. Without thinking about it, these patients won't get well. That's just the reality. And so, in summary, when you looked at the discussion of this case, they went and looked for other cases there. And in essence, they thought that they were putting it more in time in terms of multisystem inflammatory syndrome that can be seen with children, or even Kawasaki is like a vasculitis, but they didn't see any evidence of vasculitis. And they highlighted that the prevalence of COVID 19 associated enterocolitis is low, and the pathogenesis of the disease remains unclear. So, this is why we need so much research, because this is likely to have been happening to other patients, but not necessarily as bad as 5 or 6 liters. This is why he ended up in a published case report. But even 1 to 2 liters of diarrhea in an older person could actually cause serious harm or death if they don't improve. If we don't get an understanding of this quickly, to understand when we should be using immune suppression in the context of the COVID storm, this will have serious implications. And it brings me back to where I was at the start, which is that I am looking for these things. This is why I'm talking about this outbreak of Guillain-Barré. And I think this is going to be unique to that part of India. So we're not going to see that happening across the world. And so if you want to learn more about that, please join in. But it is now a transition as to how endemic diseases, so this is the point, endemic diseases become exacerbated in the context of a COVID storm where you now have virus circulating through a community. This is essentially what I'll be explaining, and it should be hopefully as interesting to me, I mean to you, as it is to me. And again, if you're interested in understanding more about this concept of the spike detox protocol, click on the link, fill in your information. I'll be happy to share more with you over time for people who are concerned. As you can see, all of these symptoms here are relevant. It presents in multiple different ways, and we have to find ways of addressing it. So that's it in a nutshell. Hope you found that valuable. And listen, at the end here, I'm just curious about something as I continue to be tremendously suppressed in terms of the information that I have. I just don't know what is happening with subscribers. My subscribers have dropped off a cliff. I'm no longer getting new subscribers. In effect, I'm losing subscribers, which has never happened before. So my content is clearly not going in front of new people. And or if it is, please click on the subscribe button, even if it's just for a test to see what is going on. So thank you again for joining me, and we'll continue to break down the science over the next few weeks and months. Have a good evening.